Hi everyone. Today we're going to be talking about abortion in the United States. I am Laura Larson. I am an assistant professor in the Department of Obstetrics and Gynecology, um, and we have a few learning objectives today. So the first one is to understand the demographics of abortion in the United States. The next one is to recognize the safety of abortion. The third is to know the medical aspects of abortion, and the fourth is to learn about abortion access and training. So as you can see in this graph, in 2014, the U.S. abortion rate reached a historic low. The abortion rate in 2014 was 14.6 abortions per 1,000 women aged 15 to 44, which is down 14% from 16.9 per 1,000 women in 2011. This is the lowest rate ever observed in the United States, and even in 1973, the year abortion became legal, the rate was 16.3. Still, about one-fourth of women will have an abortion in their lifetime. So what explains this decline? Likely we think it's due to increased contraception use, especially the uptake of intrauterine device and implants, but it's difficult to definitely prove this. The other thought is it the opposite end? Is there are increased abortion restrictions that are going ahead and decreasing access? Regardless, we want to know who has abortions. So abortion is being increasingly concentrated among poor women. Abortion rates have declined among all demographic groups from 2008 to 2014, but these declines vary widely per group. Abortion is, like I said, is increasingly concentrated among poor and low-income women, and these groups together accounted for 75% of all abortion patients in 2014. So you can see that in this graph here by the green and the orange line. So abortion rates continue to vary by race and ethnicity. Black and Hispanic women continue to have a disproportionate number of abortions. White women are underrepresented among abortion patients, having an abortion index of 0.7, while Black women are substantially overrepresented with a relative abortion rate of 1.9. So this red line here on the top is Black non-Hispanic women. In this green line at the bottom is white non-Hispanic women, and Hispanic women are here in the blue. So as you can see, the orange line here has over double the amount of abortions than the green line. And while we've already talked about race and income, I think it's really important to point out that women of all faiths have abortions, and 62% of women who have abortions are religiously affiliated. In addition, the majority of these women are in their 20s and not in their teens, as often quoted, and most women who get abortions are already mothers and understand what it takes to care for a child. In terms of gestational age, 89% of abortions happen in the first trimester, and only 1.3% happen after 20 weeks. Second trimester abortions is extremely rare. And since most first trimester abortion care happens in freestanding clinics and not in hospitals, here at Rush on your rotations, you're going to see a disproportionate amount of second trimester abortions. So you can see here in this dark blue that 66% of the abortions actually happen at less than 8 weeks gestation. So who's having second trimester abortions? The first group of women are women who have logistical issues. Whether they have issues finding a provider, they have issues raising funds to pay for the procedure and paying for travel to a provider, or finding child care. In addition, women with lower educational status, Black women, and women who have experienced multiple disruptive events within the last year are more likely to have a second trimester abortion. Victims of sexual assault and adolescents. Over 58% of abortions, 58% of abortion patients wish they could have received an abortion earlier. So anyone who works in abortion care who has seen patients who are trying to get money to access abortion, by the time they do so, they are farther along and the procedure is more complicated and expensive. So it ends up being this vicious cycle. Things have improved in Illinois since Medicaid now covers abortion, but I will talk about that a little more later. So next, let's talk about the safety of abortion. First things first, abortion is very, very safe. It's one of the safest surgical procedures for women. The risk of death associated with an abortion is low, approximately 0.6 deaths per 100,000 abortion, and the risk of major complication is less than 1%. The risk of death in pregnancy when it's continued to birth is about 12 times as great as the risk of death from induced abortion. On average, 8 women die per year in the U.S. from induced abortion, compared to about 280 women who die from pregnancy and childbirth. The one caveat to this is you can see within this graph, abortion is safer the earlier in pregnancy it is performed. So when you, it's still at all stages, it's much safer than childbirth, but it is safer in the first trimester than it is in the second trimester. In terms of long-term safety of abortion, there's been a ton of evidence from well-designed and well-executed studies that indicate that abortion is safe in the long term and carries little to no risk of fertility rate-related problems, cancers, or psychological illnesses. There's been exhaustive review panels by both the US and British governments, which have consistently found no association between abortion and breast cancer. And the available evidence also indicates that abortion is not a risk factor for other types of cancer. It may even protect against certain types of cancer. The decision to terminate pregnancy is complex and for some women can be difficult. However, well-designed studies continue to find that abortion is no more likely to cause mental health problems than continuing an unwanted pregnancy. I love this slide that puts abortion risk into perspective. The risk of dying from abortion is very low compared to many other risks that people are exposed to. The risk is much less than driving a car or even playing football. And the risk of an abortion in the first trimester is even less than having sex or using tampons, just because of the risk of pelvic inflammatory disease and toxic shock syndrome. So next, let's talk about how abortions are actually performed. So prior to abortion, all patients get pregnancy options counseling. So we talk to all women about whether they'd like to continue the pregnancy to term and parent, whether they'd like to continue the pregnancy and have an adoption, or whether they'd like to terminate the pregnancy. The next is we talk to the women about their support system and make sure that they feel supported in their decision. Women do have to get an ultrasound to make sure that the pregnancy is within the uterus. And you can see in this picture, here's the pregnancy here. It's about a little over 5 weeks because you can just see a yolk sac. And then down here is the cervix. We get a medical and surgical history, and then we have to get some blood. So we get a blood type and hemoglobin. And then lastly, we discuss contraception. Women are candidates for all types of contraception after their abortion, so we can even place IUDs and implants if patients desire those. So first, let's talk about first trimester, because that's the most common. So in the first trimester, women have two options. They have an option of a surgical abortion or a medical abortion. A surgical abortion happens, the first trimester surgical abortion goes up to about 12 to 14 weeks, and a first trimester medical abortion goes up to about 10 weeks. There are some major differences between the two. So with a surgical abortion, it's provider controlled, meaning the provider is doing the procedure. Whereas with a medical abortion, it's patient controlled. The patient takes the medication and experiences the abortion at home. With a surgical abortion, it's generally one visit, where a medical abortion is 2 visits generally. A surgical abortion is over 99% effective, and a medical abortion is about 95 to 98% effective, which is why you have to come back for an ultrasound to make sure that the pregnancy has passed. With a surgical abortion, after your procedure, women are going to have generally very light bleeding. With a medical abortion, at home while they're passing the pregnancy, they're going to have heavy bleeding for a few hours, but then it is going to become light afterwards. There's generally fewer side effects with a surgical abortion than a medical abortion, and antibiotics are needed for a surgical abortion, but they are not needed for a medical abortion. That being said, in well-designed studies, there is equal satisfaction between both a surgical and a medical abortion because patients get to choose. So if they get to choose and they know about the risk and benefits of both, they generally are satisfied with either of them. In addition, in most clinics, surgical abortion and medical abortion are the same price. So we try to make it so that price does not sway a person's decision for either of them. So a first trimester surgical abortion is performed using a suction D&C, which is otherwise known as a vacuum aspiration. So the D part stands for dilation. So we mechanically dilate the cervix, and then the curettage is when we use suction to remove the pregnancy. As I mentioned, it can be done in a single visit. It's completed in about 5 to 10 minutes, about 99% success rate. And sedation can be used if desired, but generally just a paracervical block. So some lidocaine injected next to the cervix and ibuprofen is all that's needed. And this does not require follow-up in most cases. In terms of dilation, most of the time in the first trimester, we'll use these mechanical dilators that you can see here. So we start with these small dilators and sequentially go up until we get to the desired size. And then we can also use this medication called misoprostol, which I'm going to talk about a few times during the presentation. So misoprostol is a prostaglandin that was originally marketed for peptic ulcer treatment, but now it's used a lot in obstetrics. So we use it both on labor and delivery to start an induction. We'll also use it to stop postpartum hemorrhage, and then we use it in abortion care to soften and dilate the cervix. This curettage portion is when we're going to use the suction to remove the pregnancy. For early gestations, we can use this manual suction here. It's basically just a large syringe that mechanically makes suction and we can remove the pregnancy. For pregnancies that are a little farther along, so generally after 9 to 10 weeks, we're going to use a electric suction, and it works the same way, it's just electric. For pain management, as I mentioned, often we can just use local anesthesia, which is just 1% lidocaine, and then an NSAID. NSAIDs, so ibuprofen and Toradol, work much better than medications like narcotics or tramadol. In some cases, we'll use conscious sedation, which is a mixture of fentanyl and Versed, which will make it so the woman is sleepy and kind of out of it, but she's not 100% asleep. And then deep sedation, which is propofol, is what you're going to see generally in like higher volume clinics or if there are difficult procedures. So the next slide's important because it's going to show what a completed abortion looks like. So this is all an abortion looks like at 7-week gestational age. All it is you can see right here, this kind of fluffy looking tissue. That's what an abortion is at 7 weeks. We'll know that the abortion's completed because we'll look at the products here to make sure we got everything out. And then also when we're done with the procedure, we'll feel the uterus and it'll kind of feel gritty, almost like sandpaper, and we'll know that we're done. In terms of complications, the risk of bleeding is less than 0.3%, so very few women need a transfusion. Infection varies depending on the studies you're looking at, from 0.01% to 2%, although it's on the lower end when we give antibiotics before the procedure. Uterine perforation is something that we're all worried about. That is making a hole inside the uterus. So that can happen in any gynecologic procedure. So anytime you put anything in the uterus, there's a chance you can make a hole inside the uterus. The risk is still very low. It's 0.04%, but it increases if you've had more C-sections or if you're farther along. And like I talked about already, death is extremely, extremely rare, less than 0.3 in 100,000. And the risk associated with childbirth is 11 times greater than with an abortion. Okay, so medication abortion. So medication abortion is early pregnancy termination before 10 weeks gestation. We use 2 medications called mifepristone and misoprostol, and generally no surgical intervention is needed. So the mifepristone is the first medication. It's otherwise known as RU486. It was introduced in Europe in 1988 and then improved for US use in 2000. It's actually an anti-progesterone. And we give that to the patients in clinic during their first visit. Then they go home, and 4 to 72 hours later, they take a medication called misoprostol, which we already talked about. It's that prostaglandin. And that's when they have the abortion at home. So the two of them work in conjunction together, as you can see on this slide. So mifepristone blocks the action of progesterone by binding to it, but it doesn't activate it. And then following the administration of mifepristone, the trophoblast separates from the decidua, and the levels of the pregnancy hormone, HCG, decline, and the prostaglandins are released locally. In addition, we add more prostaglandins, which is the cytotec, and then the uterine bleeding results. So the mifepristone induces cervical ripening, and then the misoprostol induces the uterine contractions. So there's a few contraindications to medication abortion. The first is allergy. The next is adrenal failure. The third is long-term steroid use. Fourth is an inherited porphyria, anemia, and then bleeding disorders. So there are some very common and very normal side effects of the procedure. We actually want the patients to experience some of these because if they don't, then we know that the pregnancy didn't pass. So women are going to have some cramping and pain in order for the medication abortion to work and for them to pass the pregnancy. They're also going to have some bleeding, which is going to be heavier than menses generally, but that really heavy bleeding generally only lasts for about an hour or two. The misoprostol can cause some nausea, vomiting, and diarrhea. It can also cause a mild temperature elevation that is not necessarily indicative of a infection. And then they can have some headache and dizziness. So I like to tell patients it's like having a miscarriage at home, and it's really important for these patients that they have excellent pre-counseling and clear and concise written instructions. And then patients tend to do very well as long as you have give them a lot of anticipatory guidance. Um, and then you kind of just look at it as a continuum. So heavy bleeding is an expected side effect, but then it becomes a complication when the bleeding is so excessive that transfusion or surgical intervention is warranted. So we do a lot of explaining to women how they know what's normal bleeding and how they know what's excessive bleeding. So in terms of follow-up options, the most common thing that is used is a transvaginal ultrasound in 1 to 2 weeks, and we just look to make sure everything has passed. The other thing is that you can get actually quantitative beta HCG level, and if it decreases by 50% in 48 hours or 80% in 7 days, that we know that the pregnancy is passed. In terms of a follow-up ultrasound, this is what a complete medication abortion looks like. You can see here, this is the uterine lining. It's still very thick, but that's fine. As long as there's no persistent gestational sac in there, we don't really care how thick the uterine line is, as long as the patient isn't experiencing continued symptoms. And then here you can actually see that there's still a gestational sac, so we're more concerned about that. And in those instances, we can either give patients another dose of misoprostol or they can get a suction D&C. So these are the complications of a medication abortion: excessive bleeding, so heavier prolonged bleeding, the patient feels dizzy or lightheaded, an incomplete abortion, so they still have retained gestational sac or tissue, or they have an ongoing continuing pregnancy. Okay, so next we're going to talk about second trimester abortion. I just want to make a quick note here. So it should always be called second trimester abortion and not late term abortion. Late term abortion doesn't really make any sense because if you think about it, term in OB means 39 weeks. So late term would be like an abortion after 41 weeks or something, which obviously doesn't exist. So you as healthcare providers should be calling it second trimester abortion. Okay, so there's two options for second trimester abortion. Again, there is surgical and then there's medical. And these are abortions after about 12 to 14 weeks gestational age. So a medical abortion is going to be after a medical abortion in the second trimester is going to be like a labor induction. So what's nice, the advantages of a medical termination for these women is that it allows the mother to experience labor and delivery if she wishes. It allows the family to see and hold the fetus if they wish, and it allows for a traditional autopsy. Some of the disadvantages of this medical termination is that the length of labor is unpredictable. There's generally more overall pain than with a surgical second trimester abortion, and you still may need to do surgical completion of the procedure, although this is rare. A second trimester surgical abortion is called a dilation and evacuation, otherwise abbreviated as a D&E. So this procedure is very predictable and can be scheduled. There's generally less pain than with induction. It avoids the labor process. In some women, there's an overall lower complication rate and maybe safer in some women. An IUD can be placed at the same time as the procedure. You can still have an autopsy, but it's not a traditional autopsy. And then the biggest advantage is that the patient can't see or hold the fetus. So an overview of a dilation and evacuation. Again, dilation means preparing the cervix, and then evacuation means removing the pregnancy with a combination of suction and forceps. So cervical preparation and a dilation and evacuation is a little more complicated than it is in a first trimester procedure. So there's a bunch of things we can do. One is called laminaria, the next is misoprostol. We can use mifepristone again, or we can use mechanical dilation. So here's some pictures of the cervical preparation here. It's generally mandatory after about 14 weeks gestation, and it reduces cervical trauma. So over here, these are pictures of what are called laminaria, or otherwise known as osmotic dilator. So generally what we'll do is we'll actually place these in patient's cervix the day before the procedure, and then they'll act overnight to gently and slowly dilate the cervix. We can also add, again, misoprostol, which can either be used with the dilators or can be used alone before 16 weeks. And then we can also use mifepristone. But these dilators are very, very common after about 16 weeks. And then when we're actually doing the procedure, the equipment looks very similar to a first trimester abortion, except we're also going to be using forceps. So you can see there's two types of forceps here, because generally the entire procedure can't be completed with suction. In terms of the second trimester medication abortion procedure, the medications are actually the same as what we would do for a first trimester medication abortion. So we're going to give a patient mifepristone 24 hours beforehand, and then we're going to give them misoprostol, but the difference is they're actually going to be admitted to the hospital. So they're going to be admitted to the labor and delivery ward, and they're going to get them misoprostol every 3 hours until they deliver. In terms of pain control, many women will get epidurals. You can use a PCA. You can use just IV narcotics if you need it, but it really does simulate the labor process. So the last thing I want to talk to you guys about is abortion access and training. So access to abortion varies greatly depending on where you live. The most restrictions happen in the South and the Midwest. And poor access is a major problem because not only do women have to pay for the procedure, but they also need to take time off from work, which costs them money, and then pay for travel costs and childcare. So it becomes very, very restrictive. So if you look at this graph here, so more than half of women live within 50 miles of an abortion clinic, and yet 27% have to travel at least 30 miles. So look here, here's Chicago. It's nice and blue, and we are surrounded by the sea of red and orange. So we're kind of an island in the Midwest. In addition, laws continue to pass that make abortion more restrictive. So if you look at this graph, all these red states here, so the vast majority of states, have laws that restrict abortion and are described by the Guttmacher Institute by extremely hostile. These green ones are supportive, and then the gray ones in Illinois is considered a gray state, are kind of somewhere in the middle ground. So if Roe were to fall, the only states that would guarantee abortions are the ones in the green, and then maybe the ones in the gray. Again, look at Illinois, surrounded by the sea of red. So here are some examples of restrictive abortion laws. So about 18 states have gestational age limits, so they restrict abortion to 20 weeks or below. There's some states that have dilation and evacuation bans, which really restrict second trimester abortions to only medication abortions, and hospitals, which basically just gets rid of second trimester abortions. Many states have waiting periods that require a patient to wait anywhere from 24 to 72 hours from their first visit to actually get their abortion. There's mandated counseling, which is not medically accurate in many states. So in Missouri, for example, which is close to us, they require all providers to tell patients that abortion causes breast cancer, which we already discussed is not medically accurate. And they also get an entire packet where the front page of the packet says that abortion is terminating the life of a whole and separate individual. In addition, they have required ultrasound viewing so that women must look at their ultrasound. Some states won't allow telemedicine. And then there are targeted regulation of abortion provider, otherwise known as TRAP laws, saying that abortion clinics have to have special sized hallways or special places to put their equipment that other clinics don't have. And then lastly, many states have Roe v. Wade trigger laws that basically say that if Roe v. Wade were to fall, abortion would automatically become illegal in their state. That being said, it's not all anti. There is some proactive legislation as well, and the states in greens have expanded or protected abortion rights in the last year. So that brings me to Illinois. So Illinois in January of 2018 passed HB 40. So that removed the Roe versus Wade trigger law that we used to have in place. And then we also now fund abortion for those on Medicaid. So nationally, there is a law called the Hyde Amendment that says that no government funds can be used for abortion, and that's the national government funds. So Medicaid is funded half by the federal government and half by the state government. So Illinois took on the abortion funding and is paying 100% for abortion for patients on Medicaid. And we're one of 17 states that are doing this. We do have, it's actually not a parental consent, it's a parental notification law for anyone under the age of 18. And in terms of access in Illinois, there were 40 abortion providing facilities in Illinois in about 2014. But that being said, 92% of Illinois County have no clinics that provide abortion, and about 40% of Illinois women live in these counties. In terms of abortion training, it vastly varies depending on where you go to medical school. So there have been a bunch of surveys that have gone out over the last few years looking at abortion training in medical schools and residency. So about 32% of medical schools offer at least one abortion lecture, and about 45% provide clinical exposure to abortion. In terms of OB/GYN residency, although it is an ACGME requirement to offer abortion training for OB/GYN residents, only 54% of residencies reported routine abortion training, and only 30% reported routine opt-in training. So the difference is that routine abortion training is all residents are expected to do it unless they choose to opt out, whereas opt-in is there's abortion training may be available somewhere, but the residents need to find it themselves and figure out where in the schedule they're going to be able to do it. And then 16% of residents reported that training for abortion was unavailable. And then family medicine residency, only 24 of the 461 residencies include abortion training. So in terms of barriers to abortion training, so there's a lot of them. So the first one is that there's in some states there's public funding or other restrictions on medical schools. So, if you in Wisconsin, for example, if you go to University of Wisconsin, you can't get abortion training because there's restriction on whether state employees can provide abortions. There are restrictions that limit abortion provision to only OBGYNs. And then when you're a resident, those things like the mandatory delays and the waiting periods make it very logistically challenging. And then there's also some institutional barriers. So hospitals are merging with religious entities, which make reproductive health training very difficult. And then there's an inadequate number of trained faculty to begin with to train residents. And then opt-in instead of opt-out abortion training creates a burden on the trainee to develop a clinical experience. So lastly, I just want to kind of go through where you can get abortion in Chicago. So you can get it right here at Rush. Our phone number is listed there. The other academic universities, so Northwestern, UIC, University of Chicago as well. Planned Parenthood of Illinois, Family Planning Associates is another large clinic in Chicago. There are other places as well, but these are probably the largest. In terms of support for patients, Chicago Abortion Fund is a wonderful organization which helps patients find money to pay for the procedure, but also support for childcare and travel, etc. And this exhale hotline is great for women to talk about their decision either before or after their abortion if they need someone to talk to. So if anyone has any questions or would like to talk through this more, I am happy to talk with you. My email is listed here, and I really appreciate your attention. Thank you so much.